Good evening, respected teachers and colleagues. I am Dr. Owais Ali. Today, my presentation is Optical Coherence Tomography presentation, and it will be moderated by Dr. Suganeswari ma'am. Presenting a case, 36-year-old female presented to us with diminution of vision for 2 months. She in left eye and complains of flashes on and off. Uh, she she has a significant past medical history. She's a known diabetic under treatment for 4 years. She also has a significant past ocular history with a history of a single dose of anti-VEGF as she was diagnosed with diabetic macular edema in the left eye. Uh, Her best corrected visual acuity was 6.6 N6 with intraocular pressure of 14 millimeters of mercury in the right eye. And in the left eye, her best corrected visual acuity was 612 and 660 and 18 with the intraocular pressure being 14 millimeters of mercury. Uh, this is a fundus photo with the corresponding autofluorescence picture. It is of the right eye. It is unremarkable. Coming to the left eye, uh, can any of the PGs describe the fundus photo?
This is a fundus photo of the left eye, which is showing us diffuse hypofluorescence with hyperfluorescent borders, which we are seeing on fundus autofluorescent.
Color fundus photo, sir.
Okay, the picture on the left is the color fundus photo of the left eye with a clear wet cavity and a normal cup disc ratio with an AV ratio of 2:3. The macula of the right eye is showing of the left eye is showing
So there's something at the macula. So you describe it.
subretinal pale yellow that I can see. Probably, probably.
Okay. So this is a lesion at the macula measuring approximately 3 disc diameters uh, with causing some retinal elevation.
So when you're seeing this picture, what exactly are you seeing? Are you seeing, most important is, are you able to see that there is a difference? Is it a flat lesion? Is it a raised lesion? This is what is the first thing which we want you to appreciate. So how many of you feel that what you see on the macula is a flat lesion? How many of you feel that it is a raised lesion? If you're going to tell me it's a flat lesion, you will tell me the reason why. If it is a raised lesion, you will tell also why. How many are for flat? How many are for?
Give the reason why you say flat. Your reason.
Sir, I thought it is a two-dimensional fundus photograph, so it is difficult to comment that it may be a flat or elevated lesion.
Excellent. Give to the next person and let her tell why it is elevated.
So the grayish region around looks elevated. So
Okay, the next person.
Don't look at
So the curvature of the vessels and the gray area that we're seeing around that area.
As you see, look below the lesion. Gives you a clue. Raised. Next person.
So what makes you feel that there is a difference in the picture? See, it's a two-dimensional picture, very much agreed. That is a wonderful point. But the most important thing is when you see the vessels, which is the superior and the inferior, you definitely see there is a difference, isn't it?
yes, ma'am.
It is not in the same plane. So that should give you a clue in a two-dimensional picture that we are not seeing probably everything appreciating at the same plane. And the focus also will be different. If you see, the vessels will be more clear, the one which is raised in front. Correct. The one which is down, it will not be as clear. So that is another clue that it should say that one is shifted in front, another one is staying behind. So that should be the clue on a two-dimensional picture if you are not having a depth perception. Please proceed.
Coming to the corresponding autofluorescence picture, there's a confluent autofluorescence, predominantly the hyperautofluorescence surrounded by a rim of hyperautofluorescence. Coming to the B scan, uh, so the B scan shows a subtle elevation, retinochoroidal elevation, uh, the dimensions of which could not be measured because it was too small a lesion to be measured on a B scan. No, Ronak, so this was the OCT done elsewhere before giving the anti-VEGF as she was diagnosed as a macular edema. You can see SRF over here and intraretinal cyst over here, fluidic cyst involving the fovea. And Coming to the SSOCTA pictures, this is a superficial slab. It's showing that the foveal avascular zone is well maintained. So the ORCC slab shows a hyperreflectivity in the region of the macula. Similarly, the choriocapillary show hyperreflectivity at the macula, and in the deep plexus, we can see a flow void area in the center of the macula. So this is the B scan picture. It is showing a retinochoroidal elevation with some hyperreflectivity in the hyperreflective subretinal deposits. The height of the lesion was measured to be just slightly short of 1 millimeter. So this is the fundus for FFA picture with the ICG picture. FFA in the early and mid and late phase shows hypo block fluorescence with the late phase showing a perilesional staining, and the corresponding the ICG picture of the left eye shows hypocyanins throughout the procedure. So this is the multimodal imaging picture. So in the color fundus photo, we can appreciate the lesion at the macula with some subretinal yellowish deposits with the corresponding autofluorescence, and the B scan picture and the B scan along with the fundus fluorescence and ICG picture. So as per TOFSIM, there's a mnemonic called TOFSIM to differentiate between for high risk nevus converting into a melanoma. So the tumor thickness was less than 2 millimeters. There was there is some lipofuscin pigments that are the orange pigments that can cause hyperautofluorescence. In the B scan we could not measure. There's a subtle retinochoroidal elevation. In the B scan, there is the absence of SRF, subretinal fluid, and this is the FFA picture showing. So the B scan OCT shows no subretinal fluid.
Now we stop here. So most important thing, why this case is being presented, the reason is when we are talking about, like I'm sure most of you must have got the clue what is the diagnosis. So can anybody tell what is the diagnosis now? So there is a lesion, raised lesion. We all know that it is arising from the choroid because the OCT is very clear that it is from the choroid. So now this is a pigmented lesion. Correct. So it's a pigmented lesion. It is from the choroid. And you are seeing a blocked fluorescence. You are not seeing anything underneath that. So what are the differentials right now for a lesion which is pigmented coming from the choroid and nothing fluorescing on the angiogram?
It could be choroidal hemangioma.
Okay, so if you are saying choroidal hemangioma, the reason for it. So if anybody is going to give me differentials, you will also tell why, because that it is. See, this class is for us to understand. That's all. So you will tell why.
Fever of choroidal hemangioma, the physical character of the lesions. The choroidal hemangioma usually present like this with red, oranges hues. That could be a reason.
So your diagnosis is on the base of the color fundus photograph that it is a choroidal hemangioma.
Choroidal hemangioma will have high A spikes on ultrasound.
So choroidal hemangioma will have a high A spikes on the ultrasound. How will it be? See, it's a hemangioma is a solid tumor, isn't it? So how will it be on an ultrasound? Would it have difference surface and the internal reflectivity? Would it be different, or would it be uniformly the same? On an ultrasound, how would it be? The echogenicity on the ultrasound, how will it be? Because that is one way of picking up whether it is a hemangioma or not. And we are talking about a circumscribed hemangioma, not a diffuse here. Okay, because the differential here will not be a diffuse. It will be a circumscribed.
May I ask a question, Suganeswari?
Yes, ma'am.
Yeah, Owais, I want to know how you measured the height of the tumor on the OCT. What made you pick that lower point in this image?
Ma'am, actually, they said that we have to take an estimate of the choroidoscleral junction, ma'am, because
I
the
can't hear you.
ma'am, we took an estimate of the junction of the choroid and the sclera, ma'am.
How did you get that estimate? in this patient? Because I'm trying to understand from the time your first slide came up how you picked that point. See, the main reason you're not able to get this is because it is a pigmented lesion and there is shadowing behind. And that's the first reason why it cannot be a choroidal hemangioma. This is a solid lesion with shadowing. That is why you can't get the lower limit properly. Okay. So if you're showing it this, you cannot estimate tumors like this because you never know if it is involved the sclera or not. We are assuming that the curve is the same as the choroidoscleral curve on either side. I think that is what you mean by estimate. But
Yes.
this is a case where you have a heavily pigmented tumor like this, where it's difficult to measure the height on OCT. You have to find an area where you're clearly able to see the choroidoscleral interface. Otherwise, you have to rely on the ultrasound. Okay, and to differentiate it, someone said choroidal hemangioma and you would need A spikes. Since it's a class on OCT, probably we'll concentrate on the OCT features of choroidal hemangioma, where you get vascular channels very well seen within the lesion, and it's better seen in small tumors on OCT than on ultrasound. Okay, so your method of measuring the height is not correct. You cannot estimate for approximate for tumors because you're going to use this as a monitoring sign. So you have to find some other way of estimating the height of the tumor. I can proceed, sorry.
So this point is very well taken, because in a pigmented tumor, like what ma'am said, the posterior margin is one thing which we cannot appreciate, and that too in a pigmented race like ours, it becomes very very difficult. If you are having a melanotic lesion wherein the pigmentation is not too much, we can still use. But the most important thing is we also have the not only the height, we also need to have the diameter also. That is also quite an important criteria. So here the reason why this was just shown, because it is just an approximate value, not the true way of estimating this. Not only the tumor thickness goes around in type of monitoring the lesions, we also have the other parameters, and these parameters are going to be evolving, because as we know, in the beginning the mnemonic was small, now the mnemonic is getting bigger and bigger. So I'm sure Ovis is going to tell what is the mnemonic, how do we use that. Yeah, you have to describe the mnemonic now.
Okay, ma'am. So coming to the mnemonic, it's called TOFSIM, and like ma'am said, the extension is UHH. Okay, so the first one is like we said, tumor thickness. So in this, we have taken a rough estimate. It should be less than 2 millimeters. The presence of orange pigment, which can be determined by autofluorescence. uh, Basically the orange pigment is lipofuscin deposits which cause hyper autofluorescence. Okay, so there is some hyper autofluorescence in our case as well. Coming to fluid, so the patient does not have any SRF. Coming to symptom, the patient has flashes on and off. And location, the location is if it is juxtapapillary, then it has a high propensity to convert into a melanoma. Our lesion is also very close to the disc, but still it's it's midway, I think.
No, there is a criteria which is called as the margin
margin
of the
margin
lesion.
so the
Yes.
margin should be more than 3 millimeter, meaning
If your margin is somewhere like if it is close to the vital structure, that is the disc and all those things, then in that case it becomes a high risk factor. So not a single factor will be contributing towards the transformation of a nevus into a melanoma. So why this main problem is there is because the choroidal nevus and the small melanomas, they are very difficult to differentiate, and one probably may think that this can be a nevus, but nevus transforming into a melanoma is also noted. That is why we have the high risk characteristic for a choroidal nevus. And why we should be monitoring these patients, because the simple thing is, like what has happened, the clue why people started keeping mnemonics Anybody knows why this mnemonics came into, because that is something very interesting to know. Why this mnemonic was kept for this? Where did it come from? Where was the origin from? It's a simple story. What happened was, in cutaneous melanomas, which are supposed to be more aggressive, people were diagnosed very late. So, in the Western world, they also have some criteria called as examining the entire skin of the patient. So, they, in order not to miss these things, they were the first one in dermatology. They used to call it ABCDE. So this thing of keeping also a mnemonic for the choroidal nevus, so transformation of nevus into a melanoma, or to detect small melanomas, were the criteria why they kept this mnemonic, and they kept on changing the mnemonic as they were trying to find out the risk factors when 1 plus 1 was getting added. What was the event? It is called survival, tumor survival rates, so or a transformation, malignant transformation rates, because as we talk about melanoma, they are very aggressive tumors. Because even now, with so much of targeted therapy in vogue, even now when it metastasizes, then it becomes a huge, I mean, you easily lose life when it metastasizes, even with targeted therapy and all these things. That is why the idea to screen and early detection. So if we see a high risk choroidal nevus, we do not want to miss out on transformation. So how to monitor that and how to easily remember things. That is why this TFSOM, to find small ocular melanomas with hint, so H and daily hints, like that. And then even after that, they started changing also. Why they were changing? As they found out new things, then they started changing with that. And every single modality which are being used in the diagnosis, like for instance, when we say lipofuscin, yeah, lipofuscin, you can see the orange pigment, but many a time more clearly on the AF, autofluorescence. So that is modality used for seeing whether there is an increase in autofluorescence. So you will monitor the patient sequentially to see whether there is increasing thickness. So you will see for increasing thickness, you will see for increasing hyperfluorescence, and whether the fluid level is increasing. So that is what it's not going to be a one-time event. When you see a patient, you're going to monitor the patient serially. And when you are going to see that there is an increase, and then the question of observation versus a treatment arises.
So this was a study done by Shields et al. So this study showed the OCT features in choroidal nevus. So they did a retrospective study of 120 eyes, and they divided in the retinal findings by OCT into whether there was overlying retinal edema, subretinal fluid, retinal thinning, drusen's, and RP detachment. The in 32% of the patients, the overlying retina was normal in thickness. It was thinned out in 22% of the patients, or it was or it was thickened in 51% of the 45% of the patients. So this is a general finding, OCT findings of the same study, but it was done in 2000, way back in 2005, when time domain OCT was generally used. So in some pictures you can see in this picture you can see hyperreflectivity and thickening of the RP, and in this picture you can see an active onset CNVM in a case of choroidal nevus. Coming to the next study. So this was a study done by Papastefano et al. In Moorfields. So they examined 17 patients with choroidal nevus and developing secondary CNVM. So they divided the 17 patients into treatment group and observational group. In the treatment group, 3 patients were noted to have improvement in vision after anti-VEGF injections. Patient number 1, patient number 17, and patient number 14. 2 patients had worsening of vision, patient number 4 and patient number 5, and the patient number 16 had stable vision after treatment with anti-VEGF. When you compare the observational group, the vision remains stable throughout in all the patients. So they concluded that anti-VEGF is an effective management is helpful in the effective management of vision-threatening CNV secondary to a choroidal nevus. Coming to OCTA in choroidal melanoma, so this was a retrospective study which included 11 patients, so 5 of which had choroidal nevus and 6 of which had choroidal melanoma. So the study said that the nevus generally had an intact outer retina and RP Brooks membrane complex, and the melanomas had obscured RP Brooks membranes complex. So this is a picture shown by the same study. This is the pigmented lesion, and the corresponding B scan showing showing nearly flat retina. And this is the OCTA picture showing intact outer retina. So coming to the differentials, so like I talked about the TOFSIM, mnemonic TOFSIM, tumor thickness greater than 2 millimeters, SRF, and visual symptoms mainly for photopsia, orange pigmentation, and juxtapapillary location are high risk factors for the conversion of a nevi into a melanoma. This was a study. This was a study done by Shields et al. It included it evaluated 2,355 cases. In this, the 5-year estimation was calculated as per the high risk factors that was mentioned in the previous slide. So if there is no risk factor at all, there's 1% chance that the patient will convert from a nevus to a melanoma. If there is one single risk factor, then 11% chances of conversion. With 2 risk factors, it is 22%, and in if 3 risk factors are high risk factors are present, then it will be 34%, and with 5, it will be 55%. So
Just
they
one second, always. See, very easy for people who want to, memorize this point. One single thing, what I would say is, when you have zero risk factor, just remember it is 1%, because we are talking about these are 5-year estimates. So, and when you say it is, when you say one factor, just remember 11. So that's how I keep it in mind. So if you have one risk factor, it is around 11% is the probability of there may be a conversion over a period of time. And when you're having 222, 333, 444, like that, if you keep, it is very simple, 555. So you will, because most of the patients, when you are telling that I am going to be monitoring you, when you say nevus and when you say tumor, it's a huge big difference, because it is going to be a total change when you tell a patient that no, you are having a malignancy or you are having a benign lesion. It throws them into a severe shock when we tell the whole family. So it is very, so you must not tell them that no, I'm going to be monitoring you for this particular reason. So you must give them some data on what can be the probability. So that time these numbers will help you to counsel your patient, so that they may, when you say that you have 5 risk factors, so I am going to be monitoring you, so but you tell them 50% is the probability that you may develop it, but 50% you may not. So that is how we always counsel a patient, and we keep monitoring them over a period of time. So this is something which is important, and if it comes as a question in your exam also, this is the value which you should be writing as well. Whether the question comes about a melanoma also or about a nevus, either ways you will have to write this statement.
They concluded the most important factor was increasing thickness, while the subretinal fluid and the orange pigmented lesions carried the least relative risk. So this is the same study defining a high risk lesion. You can see a pigmented lesion over here with overlying SRF, and some acoustic hollowing is seen on the B scan ultrasonography picture, and autofluorescence showing hyperautofluorescence due to the presence of lipofuscin. Coming to the second differential, the color is usually, like ma'am said, the color is usually orange in color, and it is round. It is mostly located in the posterior pole and exhibits overlying retinal edema and subretinal fluid along with RPE alterations. Ramasubramaniam and colleagues defined OCT finding in circumscribed choroidal hemangiomas. They found subretinal fluid in 19% of the patients, while retinal edema and retinal edema retinal schisis was seen in 12% of the patients, and macular edema in 24% of the patients. So this is one picture where with each disease entity we've tried to show the OCT. So this is the. Can anyone tell me what is what now?
So now this is all in one go, so that now this is one picture which you can keep it in your mind in an OCT presentation, that yes, when we are monitoring a nevus, how it looks. And the next one is a small melanoma, and this is a patient whom we have treated also. The small melanoma is treated post brachytherapy as well, the central one. And the last one is a hemangioma. So all these three patients are our patients who are even now being monitored. So this will help you to understand like how an OCT will look, how an hemangioma will look, and how a nevus will look. And like when you say there is some feature, like for instance, when you have a nevus and a fluid, always it is called a cap on. The cap on means the fluid will be on the top summit of the lesion. That can be a clue. In a melanoma, it will not be on a summit of a lesion, it will be lower down. But when we are talking about melanoma, when it grows, it becomes easy to find out, because always what will happen is in a melanoma, the height will be more than the diameter. But those things may not be correct when it is small. When it is small, the differentials are very difficult because we do not have the clues on the angiogram, double circulation, and all those things don't come when it is small. They all come when it is late. That is why there is so much of confusion between a nevus and a melanoma.
Coming to the multimodal imaging of the choroidal nevus. So just in short, a take-home message: how would you assess the tumor size? It can be done either using ultrasonography B scan or a OCT. Um, Orange pigmentation detection can be done with the help of an autofluorescence picture, and fluid can be determined by OCT, and the symptoms as well as the location will help you in the diagnosis of the patient.
Why did this patient have fluid at presentation? Not here, outside. What are the reason for the fluid?
So choroidal nevus is can be associated with fluid. So it is not that every time a fluid is there, it has to be a melanoma. No, you can have an associated CSER also apart from that, but some people call it as leaking nevus, but there is actually no leaking nevus. Nevus itself can present with fluid, and that can be treated. There are two ways of approaching it also. That is, if the patient is symptomatic, you are justified in treating the patient. Like this patient had undergone anti-VEGF treatment with anti-VEGF, and he did respond to it. He did not have fluid. But now that the fact that he did have a fluid, but that's what I told you, the cap on appearance, the initial OCT which was there, which is from outside, that had the cap on appearance. So that was one clue also to pointing out more towards an nevus. And you can have a CNVM also, but in this patient, uh, of course, CNVM was not there because we can see, but it is a heavily pigmented one again. It's a heavily pigmented lesion. So on an OCTA to see will be difficult, but then again on an angiogram also. So this patient did not have a CNVM. That is what is one. So if you have a CNVM, you can have again fluid, or a nevus itself can also produce a SRF. And if the patient is symptomatic, then we are justified in treating the patient with anti-VEGF. That is why we put that other study also. What are the associations wherein you could have an SRF?